So, what questions you guys have? Let's see. So, Keith, can you see the questions here?
I cannot.
Okay. So the newer one is harder to place on the arch. If it doesn't seat properly, it's difficult to reposition. Any tips?
Just like we said, have the patient put it on their lower arch, have them bite down. If it doesn't work, heat it back up, do it again. I've done it 3 or 4 or 5 times to do it, but always put it on the lower arch. I like the patient to do it themselves. They actually move it with their tongue. They can feel it. Have the patient grab hold of it and put it in before you heat it up. So all of those, we're just not finding. We initially found, when we tried to do it, it was much more difficult, particularly putting on the upper arch. When we do it, put on the lower arch, the patient does it. So that's why we've been successful. How about yourself, Steve?
Well, I noticed when I would put the thermocryl over the lower cuspid to cuspid and ask them to bite together, a whole lot of patients would try and bite their front teeth together. They would try to bite through it edge to edge. And I would try to convince them that, no, what you have to do is bite your back teeth together. With this device, what we're doing is telling them to bite their back teeth together, and they feel something back there to bite on. So it makes more sense. I've had 0 people posture their jaw forward and try and bite edge to edge like they used to do with the thermocryl over the lower incisors. So I find it to be a lot easier to position. We see a lot of people, and there's human variation out there. So people are going to, struggle with this. Some will struggle with it, but most of them don't. It's much easier. So another question is, I couldn't get the patient to bite through it and make it almost clear at the cusp tips. So should I try a few more times? Well, what I would say about that one is that, first of all, you want to make sure that their teeth, in fact, touch. When I do these shim stock baseline measurements of every tooth pair around the arch, and it's surprising how many times there's, a few teeth that don't touch. So it could be that you have a patient with already a posterior open bite. I'm not positive about that, but that's what I would check on. And if you're finding that patient who doesn't bite hard enough, you can just reheat it and say, look, no, you got to squeeze on it. You got to squeeze hard on it. Feel those masseters out there. I want you to feel that muscle working, kind of a thing. Just coach them. Keith?
Yeah, I don't have much to say. I just say, train the patient first. Have them bite on their back teeth and feel those master muscles, and do it several times so they really understand how hard they need to put and what they do, because you can't recruit those master muscles until your back teeth are together. If you got just your front teeth together, we have proprioception that won't allow us to fire off those master muscles. So the real key is to make sure that the patient knows that they got to make their master muscles move out and their fingers move out. That's what I tell them.
Are there any tooth shapes, Keith, that you worried about making this, like worried about locking it in, or some kind of anomaly with your tooth that you might think it would be difficult to get it back off the teeth?
No, that's the other thing about this compared to the other one. That had more material, more thickness. It would grab a hold of teeth better. This is so much thinner that it flows better, that I've never seen anything that really locked it on the teeth.
Okay.
So I haven't had that experience.
So somebody with a big overjet, so they have, and let's picture a skeletal class 2, so their mandible's way back, because they can have a big overjet in a skeletal class 1 with a narrow arch also. But if they have a big overjet, is there any tips to position the device that way?
The main thing is, I think, is put that little notch right in front of the upper anterior teeth and let them bite on it. Because if you get enough teeth into this, all the slopes on that from anterior to posterior will help reseat the condyle in the right position. So you don't have to have all the teeth in there. You don't have to have it perfect. But it still works. It still works well.
Yeah, so in the thermocryl, we would have to stack up a big pile of thermocryl just to reach between the lower incisors and the upper incisors to get some kind of a lever action or force distally on that mandible to reseat the condyles. And if you use a anterior only thermocryl, you have a large lever action there, so it's hard to keep it stable. Whereas this
Right.
one, you're using the posterior, at least that back to the bicuspid is plenty long to reach that, and you still got all those slopes to help reposition everything. Yeah. And so, when do you need to trim that aligner? You mentioned in the video. Let's go over that again, Keith.
If you have somebody that has no posterior teeth, just bicuspids, or just anterior teeth, you use that, or missing teeth, or something where ultimately the patient, you're having difficulty getting it over the occlusion. Just cut the thing off and make it just an anterior jig like we've done before with the just over the canine to canine. However, with this one, you can go back to the first bicuspid or second bicuspid, and that's plenty good. So if you're having trouble with some patients, you can just trim it off and use it like that.
So, well, what do you do? So now we got a couple questions about, well, okay, they didn't use their AM aligner. So, okay, great. Now what are we going to do? What are you doing to rehab that that MIP if you can? What's your strategy?
First of all, when they're in the office, I have them put their fingers on their condyles and push on their mandible and push that jaw back up to the condyle to see if we can reshape that disc some and get their teeth back some like that. And we will do that and remake the AM aligner. If they lost that, then remake the AM aligner in that position and try to get them to exercise in that position, and then do that. If they're still in an appliance, it's almost impossible at that point. And my feeling is, I say, it's better to breathe than to eat. I can manage your eating, but if you're not breathing, you're in the box. So we've got to look at what the morbidity is from not breathing as compared to the morbidity of moving the teeth or having your bite off. And so it's one of those caveats that you explain to patients, but it's rarely do I have a patient complain about it, even with some of the worst bites that I've created. And as I say, I've screwed up more bites doing this than I ever helped bites when I was doing restorative dentistry. So anyway, but their people are alive, so we're treating some pretty sick people.
Yeah, there's a number of ways we approach this. Somebody comes in and shows me their posterior open bite, and I ask them some questions. I say, are you having any trouble with your jaw joints? Are you having any trouble with your muscles of your chewing, or your teeth hurt anywhere? Is chewing a problem for you? And I tell you, in hundreds and hundreds of patients, the number of people who have answered yes to even one of those 4 questions is less than one hand. Some of them say, yeah, chewing's different, but they're not having painful problems with that. And then I go back to why they came to see me in the first place. Not necessarily the OSA part of it, but their problems in life, the snoring, the worry about oxygen levels to their brain, whatever it was bothering them enough to come get an appliance in the first place. And I remind them of why they wanted that. And then I also point out that, gosh, guys, in medicine, once you're diagnosed with a problem, really nothing's free after that. If you don't treat the problem, you're going to be sicker. If you do treat, and all the treatments of most everything have side effects. And so I wish there wasn't one, but this is the one that we talked about from day one. And so since you're not having a lot of troubles with this, let's talk. What else can we talk about? Let's talk about fishing or something, because it's really just as important. Now, we don't dismiss it, and we're very, very good doctors about this, and we pay attention to our patients. But I don't want you to be over worried about this. But on the other side of things, given as easy as it is for the vast majority of our patients to come in and report and show us stable occlusions over years, there's no reason not to go for that as our goal. That's what we do. Now, rehab, what we do in our office, if they come in and they show us this and they want to work on it, we have their history. We know what their jaw joints are like. We know we're probably dealing with the changes in the retrodiscal tissues or the length of the inferior lateral pterygoid or something like that. We give them exercises. And Keith, we go back to that bite guard material that you started cutting up years ago. And we give them cut up bite guard materials, and we have them use it like a Lucia jig. And so they put it between their teeth and they rock their lower jaw back and they squeeze or they push with their hand or something to put directive forces on the parts around the condyle to try and rehabilitate those issues. We don't go to MRIs. We don't do a fancy diagnoses here. We just do physical therapy, range of motion things to try and get their jaws back. And we've had a number of patients that do that a little bit, and then they come back in and we check the shim stuck, and then, whoa, look at that, it's back again. And so then we make a new AM aligner. And by the way, we're converting all of our old AM aligners to the new ones every chance we get because they work so much better. But that's what we do. We do exercises. We do the tab therapy, we call it, which is a Lucia jig therapy, and we help patients see that if they do these exercises, maybe they get some pluses to it, but we do turn them out less worried than they come in with almost all the time. What else? Does a patient's upper incisor should touch that tab? Yeah, you just put that little block on the front of the front teeth because that gives them a place to posture it when they put in. They feel that touch the front of those upper incisors, and that's a really good thing. Keith, we're running out of questions here. Anybody else have a question for us? Not that. I'll stop my screen share. Oh, I actually got one more slide, don't I? No, hang on. I got to stop this.